We're really excited to have you here, and thank y'all for giving up half of a day here on the weekend. We all know how precious weekend time is, and we hope that we're going to provide some value to you. We've got a program that you've seen, the agenda here, and right out of the chutes, we're going to get into something that's probably on a lot of your patients' minds and on your minds, and that's the whole PSA controversy. Dr. Bugg's going to be talking to you about that. But it's interesting that with the government recommendations about not screening so aggressively for prostate cancer, nationally and locally, we've seen about a 20% decrease in the number of biopsies that are being performed in the last year alone. And you say, well, wow, that's great, the recommendations are working. The problem with that is that's totally overlooked, and Dr. Bugg's going to talk about it. The facts remain that since PSA screening started, the death rate from prostate cancer has dropped by 38%. And that's not from one study, that's from multiple studies, and that's looking at SEER data. And we don't have any explanation for that other than the early detection through screening. For those of you who may not be aware, the same government task force that's looking at this and made that recommendation is trying to poo-poo colonoscopy for screening purposes as well as mammography. And I doubt, even if you think that PSA screening is overdone, and in actuality, it probably is overutilized, especially in the really elderly patients. I don't think anybody would say that we don't need to be doing screening mammography, colonoscopy, or PSA testing. And the only thing that we can figure is this is a political agenda to make the budget look better for the next 5 years, kick the can down the road just like Washington does with everything, and save some short-term money at a great long-term expense for what it costs to care for these patients later.
All right, well, I appreciate all you guys coming out here early this morning. We're going to start off, as Mark said, with a topic that certainly has been in the news a lot. I know you guys probably have had a lot of patients asking questions about it, and that's really what to do with PSA. I know we think of it sort of as clear cut and dry, but for a lot of the patients and the media and everything that's putting out, it's certainly a hot topic. Before we start, I'm curious, how many of you guys routinely recommend colon cancer screening for your patients? Is it pretty much everybody? And what about breast cancer? Is that sort of in the same category? Okay. Well, it's interesting. If we look at prostate cancer, it really correlates closely with breast cancer. We don't have the football players running around with blue shoes like they do with breast cancer. But if you look at the numbers, they're really very common. It's, with prostate, most common cancer in men, it correlates with breast cancer. We still see a lot of patients in both areas that are dying from it. And depending on the study you look at, you can make the argument that for both breast and prostate, you treat roughly 12 patients to cure one. So the numbers really correlate, but you don't hear it's very different debates on breast cancer and prostate cancer for whatever reason. Now, these are numbers we all sort of know about, but prostate cancer, again, it's the most common cancer in men. It's one of these cancers that everybody says if you live long enough, you're eventually going to get it. But nonetheless, we still have a lot of guys dying from it. And this bottom line here is really probably the area that we all really want to focus on, and that is the guys that are going to develop clinical prostate cancer at some point in their life, and how do you diagnose it and what do you do about it? If we look at the incidence of prostate cancer, this graph really just goes back to 1999, but if you look at when PSA first came out in around 1990, we had a little bump in the detection, but it's really sort of leveled off. So you don't see a big change in the incidence. But as Mark talked about, it's interesting, if you look at the death rate from prostate cancer, it's a continual drop. We're at about a 40% reduction in prostate cancer deaths. And if you look at really where that curve starts to drop, it's up here where PSA first came about, when everybody first started using it. So obviously, the logic would say, well, there's a decrease in prostate cancer death because of PSA, but there's a lot of stuff in the media and reports that people want to say, yeah, there's a drop in death rate, but we don't necessarily think it's from PSA screening. Now, I'm going to come back to this graph, but this is sort of, and this isn't in your notes, I don't think, but this is sort of an important graph to sort of put in the back of your brain. This is if you look at guys that are screened for prostate cancer and guys that are not screened in terms of death rate, you can sit there and see somewhere 8, 9, 10-year mark is really where you see these points cross. And the question is, why do we see that? And I'm going to come back to this in a little bit, and we'll talk about how they came up with those numbers. If we look at pre-PSA era, before 1990, for those that have been in practice and certainly had seen patients with prostate cancer before the PSA, most of the guys that would finally present with prostate cancer already had advanced cancer. There was already cancer outside the prostate. We couldn't cure them. And in fact, over a third of these guys actually had metastatic disease at the time of the diagnosis. Now, if we fast forward beyond when we started using PSA, those numbers have dropped dramatically. Most of the cancers that we pick up now are still contained within the prostate. It's still at a point where it's a curable cancer, and very few guys now present with metastatic disease. And again, you can make arguments, why is that the case? But really with PSA, the key factor here is we're able to detect these cancers a lot earlier than we used to. So that's really the key point on where we think PSA is really important. This was an article this past fall that sort of looks at these exact things. This was in the Cancer magazine, and in 2008 we had roughly 8,000 cases of metastatic prostate cancer at presentation, and different models have looked at what would those numbers have looked like if we did not have PSA, and those numbers are pretty high. It's really a 3-time fold increase in guys that would present with metastatic disease. So clearly, we think it's an important topic. So what's the big deal? I mean, the numbers are pretty clear cut that we've seen drop in death rates, the guys present earlier. What's the big debate, and why are we even talking about this, and why is it all over the news? Well, a lot of this, as Mark mentioned, really stimulates from the U.S. Preventive Task Force. And for those that aren't really familiar with it, this is basically, it's a group that is, it's a U.S. Department of Health and Human Services. It's a government-funded program that's made up of, or they're assigned, of 16 basically primary care physicians that include not only doctors but nurses and practitioners. When they're elected, they're put on basically a 4-year term, and the whole goal behind this is they basically look at different screenings and immunizations and sort of make up recommendations in terms of what doctors should be doing. Now, for the purpose of this talk, and specifically with prostate cancer, it is important to acknowledge that on this panel, we do not have any urologists, radiation oncologists, or medical oncologists. So the people that are sort of in the trenches and seeing this every day really aren't the ones that are making the recommendations. Now, basically what the U.S. Preventive Task Force will do is they'll look at different studies and reports on whatever topic they're wanting to report on, and they'll essentially grade the studies or the papers or the reports based on good, fair, or poor, and that's based on the quality of the study, how many patients were in the study, how the study was run. So it's a little generalized, but they do try to divide it up into 3 broad areas. Now, when we look at screening, whether it's colon cancer, breast cancer, prostate cancer, the task force will then come in behind after their review, and they'll give a grading system to how important or not important they think the screening should be for that. And I'm not going to run through all this. You can see it in your handout, but basically they, a grade A means, yes, it's a great screening study. We should all be doing it, and it has benefit. It drops all the way down to a D, which means really there's no benefit, and you're doing a lot more harm than good by doing that. This is really what they have come out with now on prostate cancer. In the spring of last year, this is when all this first really started coming about, and this is really where the American Urology Association started getting on board. But what generated all this debate in the media and all this controversy was the task force came out in the spring and basically said PSA is not any good. They gave it a D rating. They said it doesn't do any benefit for the patients. You're creating more harm. You're creating a lot of anxiety, and there's no benefit to it. Well, obviously, that has an impact when a government task force comes out and says that. This was an article that was in the Wall Street Journal shortly after that report came out, and they went and they polled different doctors in different specialties, and they said, hey, do you agree with this? Is this a good thing for the task force to be coming out and saying? Interesting, as obvious it is to us, if you look at this report, less than 25% of the doctors disagree. The majority of the doctors in the U.S., just by hearing the report, said, yeah, maybe that's a good idea. Maybe we shouldn't be using PSA, and maybe it is a bad idea, which is was a little concerning. So the AUA at our big meeting that we have in the spring there was a big topic, big discussions on what do we do with PSA and is the task force out of line. It was interesting, they actually had several of the task force guys at the meeting, and they were involved in the discussions, and they had, the AUA had the guys that are heavily involved with the research and do the studies, and there was big town meetings about it. The AUA at the end of the meeting basically came out and said they think that it was a very inappropriate and irresponsible blanket statement for the task force to come out. The evidence and the data that was presented was pretty overwhelming that, yes, it does save lives and it's important, and you're doing a disservice to the people by just making this kind of blanket statement. Interestingly enough, at that meeting, one of the chairmen for the task force was out there, and he was quoted at the meeting saying, look, we think that patients and doctors, they deserve to know what the science behind it shows. And it's ironic because we agree with that. We think, yeah, you do need to know what the science is. Just to come out and make a statement without looking at the science is inappropriate. So what does the science show, and how do we interpret this? Well, if you look at, again, what the task force does, they take studies, they take reports, and they come up with a statement. That's sort of what they're based behind. And they look at all kinds of studies that are graded. Some were good studies, some were poor, some were mixed. And then they do a meta-analysis, which basically means they get all their studies, they put them together in a pile, and they come up with a blanket statement. The problem with doing that is when you start combining good studies and bad studies and fair studies, it's going to warp your data. And the analogy we heard there, which I think is a great analogy, is sort of the whole banana smoothie description. That is, you can take 10 bananas, have 8 of them be great bananas, 2 of them be terrible bananas, mix them together in a smoothie, and it's not going to taste very good. Doesn't mean that all the bananas are bad. It means some are good and some are bad, but to make a blanket statement and say it's a terrible tasting smoothie is not a real accurate statement. So if you break down the studies that the task force used to come up with this, it's not a real good analysis they looked at. Half their studies that they looked at were pretty low quality. And again, these were what they described as good, poor, and fair. This isn't a third party describing that. Of the studies that were high quality, which we're going to talk about here in a bit, the high quality studies actually showed a decrease in mortality with prostate cancer screening. So if you look at, when you combine the studies and compare them to the studies they looked at for colon cancer screening and for breast cancer screening, interestingly enough, the numbers were all pretty similar. There wasn't a huge difference behind one disease versus the other. So if you really, there's a number of studies they used to come up with this analysis. There were probably 3 of the better known studies, the bigger studies, that really get all the discussion and what everybody sort of focuses on. There's one study, the only American study that's out there, the PLCO study, where they looked at lung, colon, ovarian, and prostate, which we'll talk about here in a bit. There was a large European study that they're still collecting data on that it involved a number of different countries. And then probably the better study, which we're going to focus on, is a study out of Sweden. And you can see these are really when the numbers were presented in 2009 and 2010. So we're just now really starting to see a lot of the true data that's coming out with all this. Well, in a nutshell, if you break down the studies, again, the only American study that we have, the PLCL study, it did involve a lot of patients. I mean, there were a little over 70,000 patients or so that were in the study. They had the guys that were in the screening part of it, they were screened for 6 years and then they stopped the screening. The European study involved 7 different centers around Europe. Again, pretty good numbers. They had 73,000 in the screening, 89 in the control. Interestingly enough, it's a little different than how we do it. They screen the guys every 4 years, which you can make the argument of is that really good or bad, but they weren't screening them every year. They were doing them every 4 years. And then the study in Sweden, which we'll talk about, not as many men in there, only 20,000 men, but where this study really separates itself out from all of the other studies, they started this study in 1994. Okay, and again, remember, PSA started coming out in the early 90s. This is the only study out there where you have a true, accurate report of guys that really have never been screened. The problem with us trying to do a study now is it's very difficult to find guys who have never been screened for prostate cancer. The reason the Sweden study is probably the cleaner of all the studies that are out there, they started this study back long enough ago where guys really hadn't had prostate cancer screening yet. So If you look at the PLCO study, and again, the task force put a lot of emphasis on this study. It's the only American study that's out there. It's pretty tainted in a number of ways. Before they even started the study, 40% of the guys that they looked at as being in the unscreened group, in other words, the control guys, had been screened at some point in their life. Once the study was up and going, you had 52% of the guys were screened at some point during the study. So you weeded out a lot of people before you even started on that. They lost a tremendous number of guys to follow-up. The comorbidity rate for the patients that were in the study were pretty high, and so they had a lot of guys that dropped out with heart disease and other issues that were going on. And very importantly, if you look at the follow-up was pretty short. They looked at just over 5 years with that, which you can ask any urologist, radiation oncologist, medical oncologist, they'll tell you 5 years is way too short to come up with any type of statement with prostate cancer. So a lot of flaws with that study. The European study had its flaws, definitely a little better than what we saw with the PLCO study. In this one, you only had about 20% of the patients were screened at some point in their life. So it was a little better study. Again, to me, I think it's a little bit of a flaw to have your guys screened every 4 years instead of an annual screening. And what is interesting with this, they came up with data at the 7.5-year mark. Still early, but a little better than what the American study showed. And initially, they came out with the report that said there was a 20% death rate on that. They came out with their statement at that time. Again, too early to make a lot of decisions, but they said you have to treat 48 patients to cure one. And so, of course, the task force jumped on this and they said, look, this is ridiculous. You guys are way over-diagnosing, way over-treating patients if you're having to treat 48 patients to save one. Well, as the data started coming out with a little longer data, at 11 years, that number jumped up to 29%. So again, if you remember that curve we showed at the beginning where the further out you get, the benefit really pops up, the European study is starting to show this. So despite what they originally were coming out with, the 48% treatment for one cure, even with this study with its flaws, you can see that at about 10 years, those numbers start to separate. And at the meeting this past spring, they had some up-to-date data which showed that curve is even separating even more. So it's starting to show more of what we have thought of all along. The problem is, right after these studies came out and they were reported, we saw an immediate drop-off in PSA screening. So despite the flaws and without really looking at it in detail, people immediately quit checking PSAs on a number of their patients. Well, if we look at what most of us consider probably the better study that's out there, again, the study out of Sweden where you truly had guys that were true controls and guys that were screened, it's a pretty good study. And it really is a study I think most of us can get a lot of information out of. Again, only 20,000 men, but it was enough to be statistically significant. And they have good follow-up. These are data that goes out to 14 years with the study. And again, importantly, only 3% of the guys that were in the controls had some type of screening before. So it's a much cleaner study to start with. Well, what we're seeing here now is a 40% decline in the prostate cancer deaths. So this study correlates along with what we're seeing with the mortality rate from prostate cancer graft. And when you look at these numbers, it drops down, the treatment to cure rate drops down to a 12-to-1 ratio. Again, numbers that are very similar to what we see with breast cancer and colon cancer. So if you look at this was the graph I showed you at the beginning. These are, again, looking at guys that were not screened compared to guys that were screened. If you look, again, this is out of the Sweden, so you can see somewhere here at about the 6, 7, 8 year mark is where you see these numbers start to separate. As you get beyond 10 years, that's really where you're seeing the big gap. And this is where we can start seeing the 40% decline in mortality rate. Even with the European study and its flaws that it'll have, at about 9 years, those two studies really start to mimic each other. So even if you look at a study that's well run versus one that has its flaws, even with that, you're still seeing pretty good drop-off in mortality rate. So after the meeting at the AUA and the task force coming out with their recommendations, the AUA said, look, this is inappropriate. To sit there and say that one statement's going to fit all your patients, to group all your studies together, to just say we're not going to screen for anything, that's a wrong statement. You're doing an injustice to your patients. And we all think, and at the AUA meeting, everybody said the task force has way overestimated what the harms and understating the benefits of PSA screening. So some important facts when you start putting all this together in a pile. It is important to separate out overdiagnosing and overtreatment. Those are really two totally different discussions. When you have somebody diagnosed with prostate cancer, what are you going to do with it? That's a whole other discussion. For the purpose of this talk, the two are different. If you look at really morbidity with prostate cancer, most of that's going to come from the treatment end. The harm that goes on with the detecting and screening for prostate cancer is not really the issue. It's really more of an issue of treating. And more importantly, if you look at the natural history of prostate cancer, it's all over the board. You have certainly some cancers that are benign that you can leave alone and not treat, and you have some that are very aggressive. So to group a disease where you're seeing all sorts of results into one statement, you can't do. You can't group them all into one deal there. So after all this has come out, we've had updated studies. It's been really interesting to watch the American Cancer Society and sort of their stance on all this. Up until recently, the American Cancer Society has really had sort of a back seat on all this, and they've not been willing to come out with any recommendations. If you talk to the guys, to Dr. Partridge and the guys with the American Cancer Society, in the past they were always, look, we're not going to make a recommendation. We don't think that it's something that we can recommend, and we're just going to sort of be hands off. Well, as the new data is coming out and the new results are coming out, here recently the American Cancer Society has now changed their website, and on their website they acknowledge, yes, the death rates from prostate cancer has dropped 40%, and we now think that this is really all going to be attributed to improvements in early detection. This is a big change for the American Cancer Society, and this is something that, as of a few weeks ago, really just changed on their website. So what do you do with all this? If we all agree PSA screening does have benefit and it does save lives, what does the AUA recommend, and what do we recommend to our patients? Well, again, we all know the two main things we look at for screening for prostate cancer is a yearly prostate exam and a yearly PSA. We all agree PSA is not a perfect test. It certainly has its flaws, but it's the only test that's out there. And so despite the downsides with PSA, we certainly feel that it's an important test to be running. And we all agree that early detection leads to less mortality and less morbidity. To go back to the task force, their recommendation with all this was to do a one-time screening when patients are 60 years old. That's not real helpful. You're going to miss a whole lot of patients by waiting until 60 to start screening, and you're really not going to get a lot of information out of that. If you look at what is considered normal and abnormal PSAs, for guys that are in their 40s and early 50s, you can look at numbers where sort of the general population will fall into. And the numbers really aren't all that high. So our recommendation, certainly the AUA's recommendation, is to start screening guys at about age 40. Now, you can look at their PSA and sort of decide, is this something we're going to screen every year, or if they're 40 years old, are we going to branch it out? You can make the argument, if you check a patient when they're in their 40s and their PSA is low, less than 1, you can make the argument of maybe not being quite as aggressive and checking them every few years to age 50. I still check my patients yearly, regardless of what the PSAs are. But you can look at the average PSAs and come up with a decision on that. But certainly the whole key with this is starting guys early is important. Again, if you go back to that curve, the death rate, the longer somebody lives, the more benefit they're going to have with prostate cancer, so with screening. So if you can pick up a cancer in a patient who's in his 40s, you're going to do that guy a whole lot more good than if you wait till he's in his mid-60s. And interesting, we didn't get into a lot of the details on these studies, but certainly the PLCO study and the European study, most of those patients were in their late 50s and 60s. So you're missing a lot of patients right off the bat by waiting on that. So we feel, and the AUA feels, that it is important to start checking guys when they hit 40 and certainly in their early 40s, and you can decide how often you want to keep checking on that. If you look at who's going to be on the radar, who do we need to refer? An easy number to remember is 2.5. That is a number, again, age-specific PSA. As guys get older, their PSAs are going to go up. If we want to pick up guys that are young and guys that are going to benefit from the most with prostate cancer screening, your young patients that are they're 60 and under, if their PSA is over 2.5, that guy needs to be referred. Okay. The PSA velocity, which all of us are certainly familiar with nowadays, where guys are having PSAs checked every year. PSA velocities over about 0.5 to 0.7, those guys need to be referred. And again, easy rule of thumb that we tell our guys, we don't really use an age, or I don't use an age where I stop checking PSAs. I go based on their life expectancy. And if you look at the curves and what the studies show, if they have more than a 10-year life expectancy with their other comorbidities, that guy needs to be screened. If he's 75 years old, he's healthy, his parents live in their 90s, I still screen that guy. Guys that are, again, that we consider high risk for prostate cancer, we won't run through all this again. Some of this we've been through. The one point I do want to talk about, which is interesting, is the whole testosterone replacement, which we have some talks on that, and that's sort of a hot topic right now. Just know that with testosterone replacement, I'm not going to dive into whoever's giving that talk, but you can see a bump in PSAs with that, but just know that needs to be somewhat of a red flag if you have guys on testosterone replacement and their PSAs are going up. What about the older guys? What about when guys get into their late 60s, 70s, and 80s? What do you do with those? Again, if you look at the numbers that are out there, if guys have been having annual PSAs and they get into their 60s and their PSA is less than 1, that guy's pretty safe. Those are the guys that are probably not going to have problems when they get older. But if you look at, to sort of play devil's advocate, if you look at the guys that are older that do have PSAs less than 1, you do still see guys that'll pop up with aggressive prostate cancers. But that's, if you want to look at what level can I stop checking my patients, that is a PSA number you can use on that. There's a lot of talk about older guys and when do we stop checking it. Again, I don't use an age, I use their life expectancy. A lot of people say, well, the older guys, if they get prostate cancer, they're going to be fine. It's not going to be something they die of. Well, that's not necessarily true. If you look at the numbers that are out there, 26% of the men that are over the age of 75 are going to develop aggressive prostate cancers. And these are cancers that they will have problems with when they get older, whether it's metastatic disease and require hospitalizations. A lot of the older guys that are diagnosed do tend to have less aggressive treatment. So by default, you're going to have some guys that do have worse outcomes on this. And so again, to use an age is probably not necessarily a good idea to be using on this. What about cost? Obviously cost is a big deal here. Are we diagnosing too many men? Are we treating too many men? Are we cranking up healthcare costs? Again, go back to before we had PSAs. Before the pre-1990s, most of the guys were presented with advanced cancer and metastatic disease. What if we quit using PSAs? We'd go back to those same numbers. Treating advanced prostate cancer is not cheap. When you die of prostate cancer, it's not a quick death. It goes on and on. A lot of these guys have multiple hospitalizations. To treat these guys with hormonal therapy and chemotherapy is expensive. Some of the newer treatments that are out there to treat metastatic disease cost up over $90,000. So it's not, you can't make the argument to say that we're going to cut costs by quit checking. That's not necessarily true on that. And if you look at the patients that go on that are untreated, your advanced prostate cancers, again, for those that were in practice before 1990, will remember the patients that constantly came in with obstruction and hematuria, and they were hospitalized and required stents and had multiple fractures. It is not a fun way to die. It's long, it's drawn out, it's expensive, and it has a lot of issues to do with that. So in summary, what are some of the take-home messages here? Again, start screening your guys at age 40. Use 2.5 as your cutoff on that. Use age-adjusted PSA and velocity. If you see a PSA bumping more than a 0.5 to 0.7 shift from one year to the next, that guy needs to be referred. And what I use in my practice, I stop screening based on life expectancy. If they have less than a 10-year life expectancy and everything's been pretty normal up to that point, you can make the argument to stop screening. If they're in their mid-70s, they're healthy, their parents live to be long, that guy probably still needs to be screened. At the end of on your syllabus there, I've got sort of a list of just some bullet points and recent articles that have been published that can give you some statements that really help to sort of look at what do we use for all this. But what I want to do, I want to stop here for a few minutes and let's back up. I want to see questions. I know you guys probably have patients that are asking about it. This certainly is not an all-inclusive talk, but really this is designed to sort of tell you guys where are we now with PSA screening and how do we use it.